with some of this, particularly in light of some of the emerging challenges that we are facing. So I would see this as a stop along the way, and that we will need to consider next steps and ongoing board scrutiny of the process between now and the end of this financial year. So I'll hand over to Lee to put
Thank you. Lee?
I'll be reporting myself, hearing myself here in a minute. We seem to have solved it. So over to Lee.
Okay. Yes, thank you, Steve. Thank you, Chair. So we did discuss this in brief at the board meeting last week, but obviously this is the first opportunity the board have had to see the details of what we'll be submitting. Just as a very quick recap, obviously board members will know that we submitted an annual plan to Welsh Government at the end of March following board approval. We subsequently had a letter, as did other health boards, on the 21st of April, indicating that our plan wasn't supportable or acceptable, which was not a surprise given the scale of the financial deficit we're facing. We subsequently met with Welsh Government on the 3rd of May to explore that in more detail and get some more guidance on where they thought our plan could be improved or further details they wanted us to look at. And that was followed up with by a letter on the 15th of May. So really quite tight timescales for us to work to, which is obviously reflected then in the timing of this being available and the need for the extraordinary board. What you'll see that we've done within the submission is significantly revise the ministerial templates. That was the request of Welsh Government. That is what we understand the Minister in particular is paying closest attention to. So that so we're not resubmitting the plan. The plan as we approved in March still stands, but we've been asked to resubmit the ministerial templates that went alongside that. So we've done that, and you'll see those covered between pages 15 to 56 in the document. So a significant set of information there, and subsequent significantly enhanced from the submission at the end of March. What we've also done is as I say, met with Welsh Government officials to understand their specific concerns. So hopefully you'll see from what we provided last week that we've looked to address each of those concerns in that set of templates. What we haven't done, as I indicated last week at the board meeting, is significantly change what the direction of travel within the annual plan or the service expectations and trajectories within that. So our trajectories within those templates are as they were at the end of March. The one exception to that is the deep talks, where we've now got a slightly more revised plan reflecting the reality of what we think we're going to be able to achieve. So I think we're more confident in what that says now, and it aligns with our transforming urgent emergency care plans. So that feels like an improvement, albeit it's not as ambitious as we'd originally set out. Since the March plan, we've also submitted our planned care bids to Welsh Government against the nationally held 50 million. And as a result of that, we've reflected that in a planned care template, which, as Steve has said, has got two scenarios within that. One is that that there is no additional money, and the second is that those bids are approved. Clearly, there's lots of other permutations within that, but for the purposes of submitting a set of trajectories, that's what we've chosen to do. The other element that we've added into the plan is the work we've been considering in relation to potential choices. So Welsh Government have, through all of our meetings, very much emphasised the need for us to look at what potential choices we could have locally to address our financial deficit. Now, we have, of course, made a lot of choices and decisions in the lead up to our March submission. So this is us going beyond that and considering what is potentially feasible options for us to consider over and above that. Now, the fact that they weren't in the March submission indicates that they were decisions we would not want to take lightly and without full consideration. But you can see the list of those in that submission, in that document that we've provided today, mainly to indicate where we've identified that such a choice could exist and where we may want to do some further work. Very important to stress that we're not making any of those decisions today or indicating that we wish to do them at this stage. It is really for further work through the course of the next 12 months. The only other point is we also have been asked through the dialogue with Welsh Government to look at where there could be national choices to support an improvement in the position. We've tried to restrict ourselves there to areas where we think it is a genuine choice for Welsh Governments. We've avoided choices that could be in breach of law or policy, or would be really impractical decisions for Welsh Government to make. And therefore the only one that we've really put onto the list is the choice around the Welsh Government, the choices that we might have around Welsh Government supporting us around our estate rationalisation plan, which is why that features in the SBAR and in the plan itself. So by way of introduction, that was all I was going to say, Chair, but I'll hand over to Hugh to cover the financial de-risking slide, if that's okay.
Lee, Chair. Just to, I guess, reiterate the conversation we had in Public Board last week. At this point in time, clearly, we only have 1 month of information to go on, so projecting a deficit for the full year is too early with any degree of precision. But in terms of the risk that we're facing, that's outlined on page 9. And we are looking at between a 20 and 25 million risk projection. That includes energy price volatility, which could go up as well as down. So excluding that, we'd be looking at something of the order of 22 million. That's driven by 3 areas of concern at this point in time. Savings that we are well aware of in terms of the challenge. Staffing issues and nurse staffing issues in particular. So as part of the stabilisation programme of work, we've seen a significant increase in the level of fill rates that we've been able to see across our sites, but in Glangwili in particular. That has meant that our reliance on agency staffing hasn't reduced to the level that we would have required to achieve our financial plan. And then lastly, oncology and oncology medication in drugs in particular, where we have seen a very significant increase in activity, which is driving the increase in the drugs budget. On a like-for-like basis, if I reflect back on our original submission to the board and conversation we had in March and submission to Welsh Government, we had included in that a saving scheme around the utility costs reducing. We've excluded that this time on following discussion with colleagues in government, which has reduced our savings plan by £1 million, but that's been replaced by £1.2 million worth of prescribing savings that we think will be deliverable with some assurance in the year. So on a net like-for-like basis, we have improved the savings table by 0.2 million. We've also now captured, not to their fullest extent, there are further opportunities out there, but the degree of productivity savings that we are seeing across the organisation and planned across the organisation for this year. These aren't savings that are cashable. We can't see a direct route to cash, but they are certainly mitigating some of the pressures that we're seeing across the organisation. And that comes to 7.8 million. We're not, as I say, including those within the savings plan itself, but certainly can reference them as improvements that are being made by colleagues across the Health Board. To reiterate the point that the Chief Executive made, de-risking is a process and not going to be an outcome in and of itself. And that's a process that we'll be following through now over the rest of this financial year, no doubt, given the scale of the challenge we're facing and likely into future years. So the process has already begun in terms of recognising the position from month one and recognising the mitigating actions that can be put in place against those. Those mitigating actions have now been received, and we will be reviewing those as an executive team next week. And that will begin a drumbeat of a review process that will continue throughout the financial year as further information and intelligence comes to light, and as further options come to our attention to pursue. So that will give us an ongoing route to understand the choices that we face as a health board. As I say, that will be a process. We're not where we would like to be or need to be at this stage, and recognise that gives the board a very stark financial challenge in the plan that we're seeing now, one that hasn't improved from our first submission, and one where we do see that there are significant risks for us to manage throughout this year. But the process we've got in place through the executive team review will give us assurance of the delivery of the actions that we can take, and we will have the assurance process and scrutiny process through the Sustainable Resources Committee, which will monitor any ongoing actions on behalf of the board. I will, of course, update the board in coming meetings on the most up-to-date position.
Thank you, Hugh, and thank you, Lee, and thank you, Steve. I'm going to open up for questions to board members on the papers that we've received, and then I'll come back after our questions and discussions to seek agreement based on those discussions. So any questions, please? If you could raise your hands. Thank you. Judith.
Yeah, thank you, Chair. First of all, can I thank Lee and others for all the work that's gone into providing us with the additional information and the paper. And I suppose, obviously, a lot of it is familiar. So some of my questions are relating to the deliverability of some of this, and also a couple of questions on sort of why some of the choices are there and why maybe some aren't there. I suppose the first point, before I ask questions, I don't want to prolong it too much, but I just think it is so important that all of what I say is about trying to maintain the integrity of the strategy, which is highlighted in the slides. But I just think it's important to keep saying that it's such an important clinically led direction of travel for this part of for the population. I know not everybody agrees with all of it, but that was, you know, what was behind it. It was about delivering safe services. So a couple of detail then. I'm looking at page 11, which is the choices page. And I'm sorry, but I think most of these are directed to Andrew, which will bring me back to my second question. I would support the review of the 24/7 GP out of hours. I'd add 111 to that. I think we've had that challenge for a while. So I think, you know, I would support us moving forward on that. I wanted to understand on number 5 why we were potentially only looking at the pre-appointed A&E for Prince Philip, which, as we know, isn't actually an A&E. So just to understand that. And then the vast majority of these choices are under Andrew's leadership, which is inevitable. He's Director of Operations. So assurance, who is going to actually be doing this work? Have we got the teams? Have we got the individuals with the capacity, capability to actually do this? And if they are doing this, are the critical things they're not going to be doing? And then my final point, if I may, is a question which, and in asking this, I'm not saying we should do it, but I sort of wanted really a further explanation about the Nurse Staffing Act. And if we did say reduce agency usage, not use Thornbury or something similar, what are the implications for us actually taking those decisions? So sorry, there's quite a bit in there, but hopefully relevant execs pick that up.
Thank you, Judith. I'm going to open it to the relevant execs. Andrew, your hand is up.
So I was just checking that we've been taken off mute because I was given a warning not just to jump in. So so thanks for the questions. I'll try and do a number of things you asked there, so I'll try and cover them all through the answer. So I think the starting point in terms of the opportunities and how they've been arrived at are that they're on the back of benchmarking, and the reason there's the focus on the Prince Philip model is that the benchmarking identifies that relative to the rest of Wales and other similar services, the cost of provision in Prince Philip for the service and the population it serves and the number of the activity is far higher than what might be seen elsewhere in Wales. So that's what prompted the question around the A&E appointed model, appointment model that Cardiff have adopted for their front door, phone first type approach. I think what's important to understand is that in the context of our urgent emergency care programme and transforming the urgent emergency care system, an important prerequisite of that working as we go forward and a key part of the programme's deliverables this year is the establishment of the clinical streaming hubs. Now, if you think about what the principle of those streaming hubs are, it's effectively to ensure that there is a far higher proportion of the population coming through on the unscheduled care pathway that we are aware of before they hit our front door. So rather than us have a huge element of activity that is people self-presenting, this is around linked to a whole process of earlier triage, use of clinical expertise to support that early assessment, to stream people in patients and the public into the right service that will address their needs at that moment in time. But another key element of that is the work we want to do to risk stratify the population as well. So there will be an element of the population at the moment that we know would be vulnerable and would be at risk of hospital attendance and admission. And there are now tools in place that we're working through. And we've got some pilots in the health board in Borth, for example, whereby we're risk stratifying elements of the population to identify those that may come into contact with our services and enable us to have in advance of that plans in place. So the whole element of our transforming the urgent emergency care programme is to minimise as far as is possible the number of people that we're actually unaware of at the time they present to our emergency services. So within that context, the concept that everything would go through a central hub lends itself to actually being able to provide scheduled appointments, if you like, on the same day or within a very rapid period to a lot of our urgent emergency care demand, which would be a change in model from what we've got. So actually, although there's a specific opportunity being identified around the pathway in Prince Philip, actually the clinical streaming hub model is one we would be replicating across the health board, and it would be something we would be looking to implement as part of our urgent emergency care strategy for the health board. So there's a wider opportunity, I think, in terms of what that does for our service, both in terms of efficiency, potential cost avoidance in terms of avoiding people having to attend hospital in the first place, but also then in terms of improving access. In terms of then how we oversee the delivery of those, we've got a programme team set up around transforming urgent emergency care, and as I've said, because of the way that a number of those actions flow from what the essential components of our future urgent emergency care model is, a lot of that work stems from within the core programme of work within the urgent emergency care programme. So I'm whilst there's a lot to do there and there's some sizable change to deliver and transformation to deliver, I'm comfortable that within the programme we can cover, we can take that forward. For the other areas that fall under my with my name next to them, for the most part, they then fall within the context of the clinical services work programme. and relate to the configuration, in particular scheduled care services and diagnostics. And there is a conversation that Lee and I have been having around how we properly resource and support that work, because of our experience currently with the paediatric consultation engagement process and discussion that we've been through. There is a significant managerial input and time requirement in supporting that. So we're just working through how, in running through a number of scheduled care services simultaneously, we would adequately support that. And it also, at the moment, although we have to discuss this in more detail and reach agreement on what we would submit, it's on our long list of options to discuss with Welsh Government in terms of our package of support around the targeted intervention escalation we are currently subject to, and how that might be a way of us leveraging transformation within the system that helps with our financial roadmap and de-escalation from the targeted intervention status. So I hope that answers, I think that answers the questions you posed.
It does. Thank you, Andrew.
Thank you. Winston.
Thank you, Chair. Thank you, Steve, Hugh, Lee, and Andrew, and others who have contributed to really reviewing quite a complicated plan, actually. Not being the IM for finance, I'm going to have a look at and comment on and just make some points, really. So first of all, I think, Steve, you mentioned that there was, I think, 50 million additional funding for planned care initiatives. And what I've noticed is that that additional 50 million is assumed to not affect the plan. So it'd be helpful just to understand what that means, or at least the underlying assumption, because it could have a positive effect, or it could actually add some more risks to the plan. Second point I just wanted to look at was, like, this looks at this sort of de-risking the plan section, which is, I think, on page 9. And I think it's really, so thanks to you, I think it's really set out the starting point of our plan deficit, the risk, the additional risks, and then the opportunities. So to my mind, I don't think we've de-risked the plan. I think what we've done is probably been a little bit more open about where the risks are. So firstly, so on the left-hand side, there are the risk of opportunities not yet converting to robust delivery and savings schemes. So that to me reads as slippage against our original assumption of 19.5 million, slippage of 10.8 million pounds. So are the opportunity, because there must be an opportunity for those to be actually back in as savings, and it'd be helpful to know whether or not those same slippage risks are the same as those opportunities or quantifiable actions which we've set out, which amount to 9.6 million pounds. I suspect they're different things. And on that 9.6 million pounds, which set out a series of various schemes, which I welcome, I think it requires quite a complicated program of work. Are those time limited, where we're expecting the savings to happen? It'd be useful to know, and I'll pick up in SRC, useful to know by particular dates when we expect those particular things to happen, such that we as a board can track that, as well as support those happening at those points in time. And then finally, because I could go on, but finally, I just want to just check on under the choices side of things, and it's one actually on page 9 as well, where we're looking to do more work in the community. My question there is, how sure are we that the community actually has the capacity to accept the further increase in access and demand there? So quite a few questions. But
Thank you, Winston. I know there's still one outstanding answer for Judith, so I'll bring Mandy in after your questions have been answered. Hugh.
Thank you. In terms of the planned care submission, we've not assumed anything in the financial plan in terms of the cost or the benefit of that. Now, clearly, there'll be additional activity from that, and we expect that to be cost neutral. So it will positively impact on our trajectories, but won't in and of itself impact on the finances. positive or negative. You're right, though, Winston, in that the delivery risk against that additional allocation then becomes a risk that we would naturally need to track, but that will be in a delivery space. In terms of de-risking the plan and your comment really about being open about the risk, I think that's the important thing really in terms of stating the challenge that we're facing as clearly and as transparently as we can at the earliest possible opportunity, which is what we have outlined here. And by being open and transparent about the risks within our delivery this year, we can then start to address those, knowing full well what we're going into. In terms of the detail of your question around opportunities and translating those opportunities into savings and the time-limited nature of those savings, as I alluded to on Thursday in our board meeting, I will make sure that our reporting through to Sustainable Resources Committee outlines very clearly where we are against our savings trajectory and outlines very clearly the actions that are being taken to translate from opportunity to delivery. So that will be part of the ongoing reporting following that drumbeat that I mentioned earlier that we'll be having as an executive team to make sure that we're tracking those effectively. In terms of your last question around community choices and actions that can be taken in the community, clearly that is a challenge. This isn't just a financial challenge of transferring resource, this is also a fundamental workforce challenge, and we can't move money around the system without necessarily making sure that the right people are also there to provide those services. And those discussions are clearly part of our ongoing dialogue as an executive. So hopefully that gives you the response, but we will provide the right scrutiny through the Sustainable Resources Committee and the reporting will be clear.
Thank you. Hugh, in relation to the reporting to Sustainable Resources Committee on that particular slippage, will that include the plan to manage the slippage, including who is holding each risk and overall, and when and where it will be escalated going through the year?
Yes, Jim.
Thank you. Mandy, you wanted to come in. I think it's in relation to the staffing question that Judith raised earlier.
It is, if I may. I think there's a couple of things I want to say. One is it's right that we have the ambition to have a workforce that can be sustainably, reliably, and yet flexibly deployed to meet the needs of our population. So that's the starting point for me, and that's what's reflected in the nurse stabilisation workforce work stream. I think anything that we do that has an impact upon fill rates or staffing levels in any of our clinical areas, and that includes our community services as well, needs to be extremely carefully thought through. One of the things that we've already started to have a discussion about, and in fact it's probably not quite as easy as it seems, is about really understanding if we were to agree to move to a position in either our 25A or 25B areas that takes us away from the Nurse Staffing Levels Act in terms of expectations of meeting the needs of patients. We need to understand what the risks will be, what the indicators and trigger the leading indicators, so we don't wait for harm to happen. We understand that if and when harm may occur, of any decisions that we've taken in association with staffing levels and fill rates. The one thing I would say, this, whilst it is about patient harm, the realisation and the benefits of the work that's been achieved within Glangwili already are there to be seen and felt, and the whole experience that we're seeing from patients and staff is so positive, particularly in our A&E departments, which is a 25A area. Now that hasn't come because we just filled the area with international nurses. That's come because we now have a much more stabilised workforce, created, yes, by our international nurses, but actually once you create the environment, people will come to work with us as well. And that's something that we're going to have to carefully consider if we decide that we're going to actually reduce staffing levels. If we take agency nursing out, which is absolutely the right thing to do, then we need to understand the impact, not just on our patients and their outcomes, but actually on our staff and the future workforce that we may or may not be able to recruit and retain. So that piece of work is going on. I haven't got the answer yet in terms of the specific impact if we significantly reduced fill rates and therefore removed agency, but our ambition is absolutely to drive out high cost agency.
Thank you.
Thank you, Mandy. I'm going to bring in Rodri then Lee.
Thank you. I think I'm on the same lines with what you said just now, Chair. I think we just need that ownership of who delivers which savings. And also here you've answered already regarding the timelines and when the predicted savings are meant to be. But I would like to also see this coming to ARAC as well. So I think it's important with audit and risk, SRC, and it'll be reported back because we need a clear timeline and not monthly, but I think we need to ensure that so by looking at it back in perhaps next December, thinking, right, we're not achieving it. I think we need to perhaps we have to relook at some of the things if they are failing. And but I think you've done a lot of work, and thank you all for doing the work on the plan. And I think it's just having to look at it in detail now and see if the savings are deliverable, isn't it?
Thank you, Rodri. And we can discuss that with Joe, the governance in relation to the two committees and including the governance review in respect of our saving schemes, which will be reported to next board. Thank you. Lee.
Actually, it's Joe that's yours.
Thank you. I'm sorry I wasn't able to get my link to work. I just wanted to come back on the issue of the community capacity question, which you raised, Winston, very helpfully, because I think it's really important to note in a public board that whilst, of course, we will be looking at our registered and non-registered workforce, this isn't just about the NHS. And it's going to be very much about how we work with social care, the third sector, and also patients and families themselves. We had ministers visit us today in Pembrokeshire, and they were very interested in terms of how we address this issue around community capacity and how we build on the assets that patients and their families have, so that we get the expectations right around the things that patients and families can do, but also the things that they need as opposed to want. So it can be very much about how we work in partnership with our own workforce, with social care, the third sector, and with patients and families themselves, because I think you're quite right, Winston, in terms of your question. The community capacity can't rely on the NHS alone, so it will be very much about that partnership working.
Thank you, Jill. Are there any other questions? Maynard.
Thank you, Chair. Yeah, as you look through it, I think this is one that's targeted for Jane, and access to primary care dental services. Very first comment in the baseline is not available until practices confirm contract options for 2023-24. I think that there are two things that occur to me there is, one, we do have some dental practices handing back their NHS contract and moving solely to private work. We're also conscious that new contracts are being worked on by Welsh Government in terms of the primary care areas. And I was just wondering where we are on the latter of those, when we will know more from the Welsh Government about the final contracts for primary care services.
Thank you, Maynard, and it's quite a complex set of issues. There have been some quite complex issues in terms of understanding activity and the balance between those practices that are working under contract reform and those that aren't over this year, and measuring the outcomes and therefore getting the finances right in terms of the targets that have been set for last year. So last year hasn't closed completely yet. And as part of that, in discussion with Welsh Government, there's been some challenges, I guess, in terms of progressing then the options for this current financial year. You're absolutely right in terms of some of the contract handbacks that we've had, but we have been able to go out to tender in terms of reletting some of those and revising the way in which they've been set. But we continue to work with Welsh Government and across the whole of Wales, really, in terms of setting out the ambitions for this forthcoming year. And the challenge has been about the measures between the balance of practices seeing new and historic patients and how those targets have been set. So we will continue to work with practices. In the meantime, what we have been doing is placing additional capacity into our urgent primary care capacity and making sure that we have that resource available. But it will hopefully be in the not too distant future that we are able to agree what those measures look like for this forthcoming year. But it's something that we continue to work with, and we're working very closely actually with each of our dental practices across Hywel Dda to make sure that we are providing the services that patients do require.
Thank you, Jill. If I could bring Joe in, please. Joe, in relation to slide 9, which sets out the financial position, I wonder if you could give your advice on the role of ARAC and SRC in considering them going forward.
Yes, thank you, Chair. So in terms of the two committees, we need to be really clear of the role, particularly of ARAC. So Rodri is the chair of the ARAC committee's right to request assurance on the process for the savings plan, as has been described by both chairs. In terms of the monitoring and the trajectories and the doing, that would absolutely sit with Winston and his committee chair. So we just need to be really clear on the roles. One is about the assurance on the process, but one is more of the monitoring and the tracking with regular updates to board chair. So I can work with both chairs to make sure we're really clear on the respective roles of each committees.
Thank you, Chair. That's really helpful. So the governance review that has been undertaken, it sounds as though it would be ARAC that looks at the process in relation to the implementation of any recommendations. Would that be the case?
Yeah, we can feed that as a bit of a wider review into ARAC in terms of the assurance on the process, Chair. And then we'll obviously we'll take that through SRC with clear actions and lead owners who will be holding to account for delivery of those. So if I work through the process with Hugh alongside the two committee chairs, if that's okay, and we can report back formally to the next board on the process, Chair, if that's okay.
Thank you. Very welcome, Matt. Thank you. I'm going to bring in Anna, then Derek, and then Chantal.
Thanks, Chair. And first to echo other colleagues' comments around the sheer amount of work that's gone into this update over a very short period of time when there's a huge amount going on for the Health Board. So I wanted first to acknowledge that. I've got some questions specifically around section 3 of the slide deck around the further choices that are being explored. So I'd first like to understand what the process was that got us to this long list, and what, if any, parameters have shifted to enable us to identify those choices now when we haven't previously done so. And then recognising it's unlikely that all of those will go ahead, nevertheless, I'm interested to think about the cumulative impact of pursuing so many changes, both in financial but also quality terms, and to understand how concerned exec colleagues are that doing this might destabilise other parts of the system. So we solve one bit of our problem and create a new bit. And then my final question is that these choices, if we can get them to work on paper, is it reasonable to assume that we have the workforce in place or accessible to us, either in terms of numbers, but also in terms of sheer energy and headspace to engage in this scale of change? Are they feasible in practice as well as potentially feasible on paper? And then my final question, Jill, to an extent has begun to answer this. I wanted to understand a bit more about how much of this we feel is within our control to bring to fruition versus how much we are depending and dependent upon other parts of the system, whether that's our public sector colleagues in, for example, social care and housing, or whether it's in the independent sector for nursing and dom care. Thank you.
Thank you, Anna. Who would like to respond? Steve?
Yeah, if I can come in first, but probably some of my colleagues will want to come in. Thanks, Anna, for the questions. I think in terms of the first question you had around the choices that led to the long list, board members may recall we had the seminar some time ago where we looked at all of the choices that we faced and the ones that we felt we could take forward and those that we felt at that time we couldn't. I think that was last year sometime, and that was the emergence of this, largely informed by the work that Hugh's team had done around where we may cost more than benchmark in areas as a way of sort of getting into the debate and recognising that that in itself only gives you one perspective on it, but they sort of germinated from that, and these plans are the ones that emerged from that process. So that's probably why these now. I'll bring Andrew in on some of these, but just my own personal reflections. I think the issue around cumulative impact and destabilisation is a good one. I think particularly when you look at 4 relatively small hospital sites, you know, at what point do bed reductions lead to the point where it's so volatile that it's very difficult to manage. I think by way of reassurance, the large majority of them, partly the reason most of them have got Andrew's name against them, is because they're already attached to wider programs of work, whether that's in transforming urgent emergency care or planned care, for example, which are looking at the whole system in the round, not just these individual parts of it. So I would hope that would, to some extent, mitigate against inadvertently destabilising other parts of the system. But I think it's something we're going to need to keep a really close eye on, because there is only so far you can go with some of this before you do start to question your ability to run services on hospital sites at very small scale. And I'll ask Andrew for his view around the sort of workforce and headspace. And I was going to say at the end, it's probably worth saying now, it is worth acknowledging that our staff have just come out of the worst winter that I think any of us can remember. That in planned care, they're facing the biggest waiting lists that anyone can remember, and in primary and community care, facing equally large challenges. I think partly this discussion and then what we take forward from here in terms of the process of de-risking has to recognise the first part needs to be a building of energy around these things. And I think to an extent we've done some of that, particularly around the 6 goals programme, around urgent emergency care, the planned care programme. But I think that's something we've got to really attend to, because people do need to have their heads up and have some ambition and optimism that we can make the changes that we're saying. But as a board, I think again we need to keep that under review. But it might be good, given that most of these do sit with Andrew, just to get his triangulation on that as well.
Yeah, thank you, Steve, and thanks, Joanna, for the question. I think I'm just to follow up on what Steve said. I think, you know, if I take the urgent emergency care actions, as I've said, when we go through the core or what's at the heart of that transformational programme that we've got in place and what's expected from Welsh Government, both in terms of the ministerial priorities this year, but also in terms of the 6 goals framework policy document, and in terms of the draft further faster policy around integrated working, a lot of those actions that we start to describe are natural conversations or issues that would arise from implementing those models. So I certainly don't feel in themselves the urgent emergency care actions are additional to what we might already have been considering having to take forward and implement and work through. I guess the challenge on some of those will be more around if we start getting into territory whereby it looks like it's more of a significant service change discussion, then I guess that's where we may start to think about the capacity constraint, just in terms of servicing that as an engagement and consultation process to do that justice, because we've got I think as a health board, from what I can see, we've got a reasonably good reputation for managing those conversations and processes, but in doing so, we know that they take time, and that's a challenge. So we would need to keep a close eye on that. I think this, in terms of some of the others, the planned care areas, a lot of those areas we've selected because we know there are issues either now or potential issues in the very near future. If we think about what's on that list, we know we've had board conversations in the last 7 or 8 months around critical care services and emergency surgery services, which are both key parts of that work. And in some regard, in delivering our elective recovery plan, some of the configuration issues around elective surgery would make that more deliverable and more manageable for some of the operational teams than the current model, whereby we're trying to manage that over a number of sites. So I think there's an element of these are questions and issues we will be working through anyway. I think what identifying them in this way does, and linking them into the Transforming Urgent Emergency Care Programme, the Clinical Services Plan and Work Programme, is it ties a bit more process and potentially resource and support from within the organisation to enable us to take those forward. As I said earlier, I think there is a challenge, particularly around the Clinical Services Plan and the headspace for services to both deliver the elective recovery plan, but also engage fully and support engagement process around planned care configuration. That's why Lee and I have had a conversation. It's sort of part of the conversation we want to have with Welsh Government around the TI support package that may or may not wish to support us with to help drive some of our financial roadmap. I think the other part of this that is in my mind is I'm also giving some thought to how, from an operational perspective, we talk a lot in the clinical sense around splitting sort of planned and emergency work. I'm trying to think very much in the operational space around how we may look at better balancing those activities from a operational response perspective, so that we can free people up to deal with some of the kind of planned activity, if you like, and the service delivery and change and transformation piece, whilst not being bogged down so much with some of the day-to-day operational pressure that they face, and often can be distraction in terms of delivering that. So there's a few things I'm doing in the background to this to try and think through how we can add more resilience and robustness to our approach to this over the course of the next 10 or 11 months and beyond. But it's something I'll keep a very close eye on, because as Steve said, everyone's very tired after a very difficult winter and a difficult period prior to that. And so managing their energy levels and their capacity is going to be something that's really crucial to our success.
Thank you, Andrew. Anna, did you want to come back in, or is that sufficient?
If just very briefly, Maria, if I may, I'm not sure I quite heard in any of those responses a response around the parameters. So, and it feels important to do this because I guess this is not the last time we're going to look at this. And so whatever the parameters are that have shifted this time around, they're likely to have to shift again. So by that, I mean that for the choices that have not been included in the end of March iteration of our plan, what is it now that has allowed those to be included? Is it simply that we have, the passage of time has allowed us to develop some more options, or have we had to change the basis on which we are including potential choices? Is it, in other words, becoming, are we including increasingly either high risk or unpalatable in some sense options that ideally we wouldn't be in a position to have to include at this point in our development? They may be strategically consistent with our direction of travel, but is this something that we're going to want to do in the here and now? So I suppose I'm just trying to understand, at the end of March, some of these things weren't in here. At the end of May, they are in here. What's changed to enable that to be the case?
I'll say something and then Andrew won't. So these choices, well, you're right in the sense that they weren't evaluated into the plan, but they were already things that we were working on as a team. I think what we are saying today is that given the financial position that we find ourselves in and the forecast that we have, firstly, a need to kind of be transparent about those in the sort of public domain, which is why they're in the public papers today, but also to recognise we're going to have to find areas within them or ensure that we have fully explored areas within them that can deliver this year. We didn't commit to them delivering financially this year, but given where we are, that's part of the piece of work we need to do to try and address the challenge we're in. So hopefully, I mean, it isn't new things. There are things we were working on, but it's become a more sharp-edged and a more need for more transparency about that, given where we are.
And I would just add, I think, Anna, that Obviously, the planned care services that we're talking about in here were all part of the clinical services plan that was included in the original submission and that we had discussed abroad in March. And I think on some of the urgent emergency care items, they were issues we were working through, but probably hadn't got to the level of granularity at that point of understanding the natural implications of some of the models we were working through. So there's almost a passage of time element in that, in terms of where we were and where we're now at. I hope that helps. Sorry, I didn't do that justice last time.
That's great. Thank you very much.
Thank you. Delith and Chantal.
Thank you, Chair. Thank you, Andrew and Steve. And I think my question carries on from Anna's and from some of your responses as well about transparency and communication. And I think it's key that you are and we are transparent with our public, because this is going to be a very disconcerting and anxious time for our public. So what really are your plans to engage and involve our public and our staff, because our staff are our public too, they are part of our communities, and we really need to ensure that we put our people and our communities at the heart of everything that we decide. So can you please just tell me what are the plans and the timescales for communicating with the public?
I think we'd all agree, really important to ensure that we are transparent. I think, again, Andrew may want to come in on part of this, but firstly to say those things on those two slides are things that are the subject of detailed conversations with our staff. They are things that are internally that are being explored as part of those, particularly those two big programs, but not exclusively. When we get to the point where we believe we have a plan that may require engagement and indeed consultation, we will then need to pull together plans to deal with that in the context of whatever we're trying to change. So that will be very much a second stage, Delith, because I think it's worth pointing out today that these are items of discussion, albeit picking up the questioning of Anna, things that we need to sharpen given where we are. But at the moment, no decision's been made about anything that would lead to service change. So those plans will come as a second step. Andrew agrees. So you don't
I don't know whether Lee would want to come in, because there's something probably around the wider process around the clinical services plan and how we're managing that based on our past experience as well.
Yeah, and I think there's always a dilemma, isn't there, as to when you engage and when you make things public. I think what we're choosing to do today is be transparent about this at the earliest opportunity, and as Steve says, as the plans develop, and when we reach a point where we think there is value in public engagement and consultation, because we think there is something we genuinely want to look at, then certainly we'd be intending to do that either through clinical services plan as a mechanism or bespoke engagement processes as we would normally. And we've done a lot of that recently, and we certainly would continue to do that. And obviously, I can see Mansell's also on the call today. We'd want to do that in agreement with Llais. I guess just one point to make on it is if you look through the list, what we're not necessarily looking to do is reduce access or the quality of services for patients. What we're looking to do is try to balance the challenges we've got around sustainability and the financial position with where we think there are opportunities to improve some of that access and change services change service models for the better. So I guess I'd just caution against interpreting them as a negative list. Hopefully what we'd be looking to do is see these as opportunities to progress our strategy, improve services to patients, and at the same time deliver some benefits to the financial position and sustainability issues we've got.
Thank you. Chantal.
Thank you, Chair. In addition to all of the questions that have already been asked, I'm just wondering, given that the letter that we received was about the fact that the plan was not supportable and acceptable, now that we've made those additional requirements, how confident are we that the plan will be now supportable and acceptable by the Welsh Government? I think that's one of the questions. And the other question is around timelines. How confident are we in terms of, given the volatility and the unpredictability of some of the things that will happen, how confident are we that we're going to be able to achieve what we say we're going to achieve in the plan? Thank you.
Thank you, Chantal. Steve.
I'll come in and the team might again want to also reflect on some of that. Thanks, Chantal. I think in terms of supportability by Welsh Government, it's difficult to know at this stage, but I think when we come to the end and look at the recommendation, I think there's some further amendments I'd like to make to that, to recognise, as we said at the beginning, that this is a process. And I think what we need to be able to describe to Welsh Government is where we are with the process and how we're going to take this forward and to provide further updates going forward. So I think whatever the initial response may be, we need to commit to and be clear with them about how we're going to continue to improve on the position we've got in place. In terms of timelines and confidence in delivery, again, I think that comes down to, we've got a very clear set of timelines around the savings plans as they are. Of course, the financial analysis is that even with that, we're not going to be able to deliver our financial position. So the timelines on mitigations, it's fair to say, are still being worked on because we haven't got all of those mitigations in place yet, and we'll need to do that as a team. But again, for me, that comes down to the process now going forward to ensure we nail that at every step of the way, including those 2 slides with the choices that we've talked about. So I think it's something that we need to ensure we keep our eye on, Chantal, that we've got clear timelines as plans reach the point where they start to be implemented.
Thank you. Thank you.
Thank you. Maynard.
Let's go back to the subject of monitoring, if I may. Obviously, within the plan, we've set out our planning objectives, and those are aligned with various committees, and they'll be monitored by those committees. I'm assuming that SDOTC will still be monitoring quarterly delivery of the plan as we did last year. But I'm not clear what monitoring a Welsh Government will require in terms of delivering the ministerial objectives. Are we having now to develop another set of reports for Welsh Government showing our progress against the ministerial priorities, and how does that fit in with the monitoring of TI, and is there going to be a lot of additional workload in terms of pulling all this different monitoring together?
Steve?
I'll come in briefly on that, but and then Hugh actually wanted to come in as well on a separate point, Maria. So if it's subject to me answering Maynard's question satisfactorily, we can then move on to Hugh if that's okay. Yeah, just to say, Hugh, Maynard, we have the normal processes to monitor through the IQPD. So that will be the process by which Welsh Government will seek assurance on the delivery of our plan. It does overlap with, and there has always been a degree of overlap with, the targeted intervention work as well. I think that is more clear now than it has been, but there is a degree of doing it in 2 different contexts, shall we say, because there is so much overlap between the 2, particularly on the finances. But that's something we've managed so far. Our TI meetings are only quarterly, so it doesn't add hugely to the reporting requirements that we also have to report some of this through that separate mechanism given our status. Is that okay, Maynard?
Yeah, just concerned that there's already a lot of additional pressure on the executive team in terms of delivering monitoring. And I don't want us to get into a situation when you're spending so much time writing reports about what we're actually doing that it gets in the way of us doing and delivering.
Yeah, no, good point. And I would also say probably there's an awful lot of pressure on our Welsh Government colleagues given the challenges across Wales. So we need to work together to make sure we do what we do.
Yeah, thanks, Steve.
Thank you, Hugh.
Yeah, Chair, thank you, and forgive me, my virtual hand doesn't seem to be working very well. Just directly responding to Maynard, our processes have all been set up already through the integrated performance report to make sure that we're capturing our trajectories and delivery against those. So it doesn't add in and of itself in terms of workload, but clearly in terms of the focus, then it does create an added expectation on focus. I wanted to come back to the question, Chantal, that you raised about acceptable and approvable. And clearly, sitting here as a board where we are looking at a plan that is in excess of 100 million as a deficit, is not a comfortable position for any of us, and not least me. But what we also have to recognise is the reality of the challenges that we're facing. And I think, you know, we have been clear over the last 12 months in terms of the demand side challenges that we're facing through the demands on our services, the delayed transfers that we're seeing across our services, the continued demand for oncology services, mental health services. They are all adding to the pressures that we face, and the reality of the supply side challenges we're also facing in terms of the ability to recruit nursing and medical staff, but also therapies, which is contributing to the financial challenge that we're facing, and of course the configuration challenges, which we know we are as part of the reason behind our work on a healthier Mid and West Wales. So while this isn't an acceptable position for any of us to be in, it is a reflection of the reality that we face. And that, I think, is something that we can be clear about. The critical thing for us is clearly our response to this over this year. And as we start to see programmes of change delivering, then we can build greater assurance into the trajectory that we're seeing in our position. And going back to the original point I made around de-risking being a process, not just an event, I think this will be a continual process that we'll be revisiting each month through this year. And as we go into the medium term, will contribute to the delivery of our medium term trajectory as well. So in direct response, clearly it isn't an acceptable position for us to find ourselves in, but is a real reflection of the challenges we're facing.
Thanks, Hugh. And based on that, the challenges that we are facing, there must be similar challenges across the whole of the NHS in the UK. How do we compare in Wales with other health boards and our financial position?
In terms of direct comparison, I think every health board is grappling with a similar scale of issue. Across the UK, it's very difficult to compare like for like. So the intelligence that I have from across the UK is much more limited, but I'm not sensing any significant difference in the issues that are affecting health services across the UK, although the scale is difficult to compare. But across Wales, we are all broadly facing a very similar level of challenge.
Thank you. Based on the scrutiny and the discussion that we've had as a board, Steve, would you like to recommend what we should, how we should word our actions going forward as a board for us to consider?
Yeah, thank you, Chair. This is by way of general summary, and then I'll attempt to just make some amendments to the recommendation, just to sharpen it up a little based on the discussion we've had today. But just some general reflections first. I mean, I think it's, as Hugh said, and as others said, this is an enormously challenging situation, not just in terms of the scale of what we're facing financially, but also in terms of the where the NHS is now and what it's been through over the last couple of years. I would take, if I can take any optimism from this, is that we're having this very detailed discussion in May and not in the latter part of the year, when winter is approaching or upon us. But we are in a system today that is still surged to winter levels of demand, even though it feels better than maybe it did. I think for me, that boils down to needing to ensure that we have a very clear set of processes, and indeed picking up some of the discussion around committee scrutiny and assurance to board around the actions that we are taking, so that we can be sure that in this context, in this difficult environment, we are doing everything we can to ensure that we are rising to this complex set of challenges. So I've been reflecting on where we are and what the plan is saying. And I think there's probably 4 things that I want to build into our processes going forward, and this will be part of a weekly process with the executive team that we have started. We started a few weeks ago, but we'll now need to gather pace. So that will be around the choices work, the stuff that we've already talked about, and seeing the extent to which we can move those into deliverable plans, both in the current year, but also in the longer term. So there will be a need at those weekly meetings to review those. In terms of our current savings, a review and an ongoing focus on the governance, which I think picks up the point around our capacity to deliver on those things. So that's about the people we've got in place, the clarity of the plans, and reviewing that on a weekly basis with the team to drive our delivery. To also include in that the emerging pressures. I think what we've got here from Hugh and the finance team is what might be described as a reasonable worst case scenario based on where we are today, but of course other things may arise during the year as well. So the process needs to look at the emerging pressures and agree rapid mitigations around those as they emerge during the year, and the additional recovery actions that we could be taking given where we are today, and focusing ourselves on the delivery of a 2.5% overall minimum delivery target, however we get there through a combination of the above. If the board are happy with that, I'll work with Joe in particular around the assurance that will need to be provided to each of the committees, because there's clearly going to be quality and safety issues for our as well as issues particularly for our Sustainable Resources Committee. So we'll pull together a programme around that that the board can be assured has got the proper oversight of. I would also, because we've got a number of things in train, which today really is a snapshot of going into Welsh Government, whilst I would want to seek approval from board to submit this supplementary information, that through the next month we continue to work on all those areas, and that I write a further accountable officer letter to the Director General at the end of June to provide an update on the progress we've then made against that financial challenge set out today. And beyond that, we can think at board at the end of July about ongoing overview at board level in public board meetings. So I would just tweak the last part of the recommendation to say that that further work in June will culminate in an accountable officer letter back into Welsh Government to update them on the improvements in our financial forecast that we've been able to achieve through that month.
Thank you, Steve. Is the board happy to go forward with that supplement to the recommendation, and also all the detail in relation to process? Yeah, thank you. Judith, did you want to come in then? No, you just said yes, sorry. I'm sure all the independent members have, will join with me to say a massive thank you. This is a huge amount of work by each and every one of you and all your teams. Thank you to the governance team for just organising this extraordinary board meeting. It was very important that we had this opportunity openly and in public to discuss our plan. We, like every other board in Wales and beyond, are facing huge challenges, and we have a workforce, including all our executive team, who've come through the worst winter in living memory after the challenges of the pandemic. And we're as well as here to scrutinise, we're also here to support you going forward, because we all need your energy as well, and your optimism and your hope and your delivery. So thank you very much for today's meeting, and we will be meeting again at the board seminar and then in July at the open board. So diolch yn fawr to everybody. Thank you. Bye.